So tumor mutational burden, that is requiring a DNA test from the patient's tumor, is something that we've been looking at in trials as a potential biomarker. Just on the day before this meeting started, a press release relating to the CheckMate 227 study suggested that actually that marker may be less predictive and more prognostic, in other words, not quite so useful for selecting patients, but that is, as I say, is a subject of a press release, and we'll await further data at another meeting in that respect. Moving from tumor mutational burden in tumor DNA, we're now hearing this weekend about blood tumor mutational burden, so-called BTMB, and that's of course quite an attractive biomarker because it's a blood test, and therefore the patient doesn't necessarily need to offer a tumor sample, and in some settings, particularly in lung cancer, that's a very major issue. So we'd love that to be the answer, and some early tantalizing data presented at a previous ESMO and published this year in Nature Medicine suggested that may be a way to go. At this meeting we've heard a little bit more about blood tumor mutational burden, and that suggests that in fact the patients who don't have enough DNA in their blood for that test have an even better response than those with the positive biomarker, which is perhaps a little bit paradoxical at first. But really that's potentially very logical, because the patients who have a low amount of disease in their body, a low tumor burden, probably have a low circulating free DNA burden as well. So that implies they're likely to be in a group that do relatively well on these drugs. So I'm probably making this sound pretty complex, and that's because it is. The conclusion after a lot of discussion and a lot of new data presented at this meeting is that really the best biomarker still is PD-L1 in the tumor, and tumor mutational burden is work in progress at the very best.